Center conference with the overall theme of advancing pediatric pain care equity, addressing challenges and opportunities in low and middle income countries. I'll be your moderator for this session. I'm a pediatric anesthesiologist and pain physician from Sick Kids Toronto, and thank you so much to the organizers for welcoming me as a moderator today. I will be moderating this morning's session on cultural dimensions of pediatric pain, understanding and addressing beliefs that shape care in African contexts. And I'm very pleased to introduce Professor Tonia Onyeka. She is a consultant anesthetist, pain medicine, and palliative care physician at the College of Medicine, University of Nigeria, her alma mater. She's the founding and current head of the Pain and Palliative Care Unit at the University of Nigeria Teaching Hospital, where she leads a multidisciplinary team providing specialized care for both adult and pediatric patients with palliative care needs. She's also the Associate Director of Ivan Research Institute in Nigeria. Professor Onyeka currently serves as the National President of the Hospice and Palliative Care Association of Nigeria and holds membership in several prominent professional organizations. These include the African Organization for Research and Training in Cancer, the American Society for Clinical Oncology, the American Academy of Hospice and Palliative Medicine, and the International Association for the Study of Pain, IASP, and she's Associate Editor of Frontiers in Pediatric Pain Journal. She's an active member of the College of Medicine Research and Ethics Committee at the University of Nigeria. Additionally, she contributes to global research efforts through her involvement in the Africa Survivorship Working Group and the Implementation Science Special Interest Group of AORTIC, as well as the Implementation Science and Global Health SIG of the Consortium for Cancer Implementation Science, an initiative of the U.S. National Institute of Health, NIH. You're a very busy person, amazing credentials. I'm so excited to hear your talk today, and welcome to our meeting. Thank you.
Thank you. Thank you so much for having me. I'd like to thank everyone at Sick Kids. I mean, this is a big opportunity for me to share some of the things that happens on the African continent with the rest of the world. And I'll be looking at cultural dimensions of pediatric pain, and we'll try to understand and address the beliefs that shape pain care in children on the continent. So Deepa is given some of my disclosures. I'm an anesthesiologist, pain medicine physician, and palliative physician at my university, the University of Nigeria, and I'm also the national president of HPCAN. So as a background, I'd like to say that in African settings, there's a lot of interplay between religious, cultural, traditional beliefs that kind of shapes the care we give children with pain. And we all know that pain is a universal experience, but its expression and its management are altered by culture. And therefore, it's important that as we understand these influences, it helps us as clinicians to be able to give equitable and effective pain management to these children. So today, we'll look at some of the drivers of pediatric pain expression in Africa. We'll look at the gaps in pain management for pediatric pain on the continent. And then we'll try to propose some culturally sensitive solutions in terms of practice, education, and policy. So where are we at with pain in children? Diverse sources of pain. In Africa, largely, it used to be some years ago, it used to be road traffic accidents, but currently the highest source of pain in children fluctuates between malignancies, that's cancers, and of course, conflicts of war, so injuries from war. So those are the big two. So of course, not to talk about issues with sickle cell disease, issues with burns, like some of my colleagues already talked about burns. So these are some of the sources of pain for children on the African continent. And why does it matter that we look at the management of pain from a cultural perspective? First of all, we all realize that there's a high burden of pain on the continent, especially acute pain. But more importantly, we have the burden for procedural pain in hospitalized children, especially where we have to set lines and take samples. we don't do anything, we largely don't do anything for their pain, for those procedures. And neonates are especially vulnerable because they can't voice out the fact that they are having some pain. So we need to look at insights into how children on the continent express their pain, how their caregivers, be it the parents or close relatives or higher persons, how they interpret this expression of pain. And then the myths, how myths around from the culture, from the tradition, how they affect and encourage some of the beliefs that might interfere with proper pain management in these children. And of course, it matters because when we're not able to document these children's pain, we're not able to assess them effectively, and therefore we have a lot of opportunities that we miss to treat their pain. So some of the concepts we'll be mentioning a lot today as we go along is what we're defining. So brief definition for culture is a way of life of the people. Pain expression, what is that? It's just an observable verbal and non-verbal manifestation of an individual's subjective pain experience. A cultural competence is simply the ability to understand, respect, and effectively engage with people from diverse cultural backgrounds to ensure that they get equitable and quality care. So going to cultural competence, which is the meat of this discussion, we have about five components. For us to consider a care that is competent, especially a pain care that is competent, we need to look at awareness, self-reflection, ourselves as healthcare providers, make sure that we're able to recognize the biases that may exist as we provide this care and ensure that they don't get in the way of our care. Knowledge. As healthcare providers, we need to know about the patients, where they're coming from, what do they believe in, where they're coming from, what is the cultural beliefs and the practices they have been into concerning the pain. Then skills, we have to learn as healthcare providers how to communicate in a culturally contextual way that the pain is going to be managed and how the pain is going to be managed. And attitude, cultural competence involves respecting the patient with pain, respecting the family, and being humble to listen and give a listening ear to whatever the complaint is. Then, of course, the very important one, which is organizational or systemic dimension, which would involve policies that are on ground within the hospitals or the healthcare facilities to ensure that the institution commits to eliminating pain in a culturally contextual way. So what is the rationale and importance of ensuring that pain management in African children is driven by the context? First of all, is that when we ensure that our care is culturally competent, it helps to reduce the disparities in access and inequalities, and it gives us good outcomes. So nobody's marginalized. Nobody says, I didn't get the care I deserve. Secondly, it improves patient-provider communication, improves trust. The patient and their families, they trust you better if the care is culturally competent. Thirdly, there is an alignment between the culture and an alignment with the language and the communication, which makes the patient and their families come back for more care. So you don't lose them to follow up. And then, of course, it ensures that the patient, the child in pain, and their families have a good experience. And there are studies that have been done that says that hospitals that had higher cultural competence had better scores in their doctor communication, they had better scores in the hospital rating and in the recommendation. So there's a lot of benefit there if we ensure that the care of these patients in regards to pain relief and pain care is culturally competent. So what are some of the things that we know affect the expression of pain in these children and how pain is approached on the continent? We know that in Africa, a large number of individuals believe on traditional healers. And these traditional healers have the role of healer, they have the role of gatekeeper. So they have the ability to say they have portions, they have herbs, they have charms, they have enchantments that they can make to take the pain down. So the people naturally in the communities would drift to the traditional healers. They're also the gatekeepers that say, no, we don't want this. This is alien. So they might, in some institutions and communities in Africa, we find these traditional healers being the ones to say, no, we won't take the orthodox medication. No, so they are the gatekeepers. So as a healthcare clinician, a healthcare worker, you need to have that at the back of your mind so that in your approach to the management and care of the African child with pain, you take this into context, and we're going to see how we can do that. Then, of course, I give an example, like the Soto people of Lesotho, they believe in a spirit called Balimo. They say is a spirit that inflicts pain to individuals who do wrong. So there's some culture similar to that that says you're having pain because you are visited by the gods, is a punishment from the gods because you did something wrong, either then or in the past. And then the Igbo tribe in Nigeria, where I come from, we have a traditional surgeon. So these are individuals who didn't go learning surgery in any university or any medical school, but they have skills that have been passed down through traditions, with traditions about male circumcision, and they do it without any analgesia. So these are the kind of individuals that some of us as healthcare workers in Africa would have to contend with. We have to deal with the reality of the cultural context that some of these children are coming from. So here is a framework that is very interesting, but it's just an interplay that tells us how the culture and the belief system of the individuals interacts with the family beliefs, the family expectations, and of course, the expectations of you as a healthcare provider. So there's an interaction between the three, and how all these three, when they interact, how they affect the pain expression for the child, the African child. So we see that, for instance, if you have a culture, and I'm giving an example like this young man, you can see the screen, he's of the Fulani tribe. So many West African countries have the Fulani tribe, and Nigeria is inclusive. So the Fulani tribe have a custom, which is a festival called Sharo, where young boys, when they have to go through this ceremony to come of age, they flog themselves and they beat themselves, and they are not expected to as much as wince or cry or express any form of pain. So children in that culture, the Fulani culture, grow up with the expectation that they don't show pain, no matter how painful it is. Even if it's a 10 out of 10 on a numeric pain rating scale, they won't show you any pain at all. The same thing for Fulani women in labor. They don't utter a word, they don't cry. So these are some of the contexts. I mean, it's a family expectation. So woman is going into labor, she's Fulani, she's not going to cry. You're not going to know she's in a third stage of labor, a second stage, or she's brought into, you won't know, and the baby will just pop out quietly. So these things are there. Then of course the health system, because there are a lack of training and some of the healthcare providers don't know some of these cultures exist. They might run into a Fulani child who has pain from something, for example, cancer, and because the child is not expressing pain, they may erroneously document the pain as 0 out of 10. So these are some of the things we need to consider and see that these influences affect the expression of the child's pain and the assessment and care of that same child. So what is the global evidence for pain care and the context in which it is received? We know that cultural norms influence how children express pain, whether they feel it or not. But then we know that children who come from expressive cultures, they tend to cry and verbalize more than others that come from a culture where pain is suppressed. And research has shown that minority children tend to receive less adequate pain relief because of some of these cultural considerations. But what is happening in Africa? In Africa, we find that more than 54% of hospitalized children have their pain either untreated or undertreated. And among these, we find out that many of them are not getting opioids, especially because despite the burden being in Africa, the consumption and the availability of that opioid is so minute, less than 1% of the global total. Then we find out also that in terms of assessment and documentation, less than 25% of children's charts have documentation on the pain intensity, on the pain score. And in Africa presently, very few places have validated scales in the local languages. So what are some of the influences from the family? Because the family also can influence the expression of pain, as I mentioned initially. So parental anxiety, parent is anxious, child generally will be anxious, and child will declare more pain. If there are pain beliefs, like a Fulani child who grows up knowing they shouldn't show pain, then you are not going to be able to get pain using a regular scale, a regular validated tool. And then, of course, coping mechanisms. Those are things that can shape the child's pain reporting and management. And it's been proven that if there's a family history of pain in a parent or somewhere in the family, that child who has pain is most likely to have a history of chronic pain down the line. And then, of course, we see, of course, the influence of socioeconomic status and the influence of maternal health in the reporting of pain by children. Then we can't run away from how religious and spiritual influences shape the child's pain expression on the African continent, because you know Africans are largely very religious, very spiritual, and there is no fine line between religiosity, spirituality, and culture in Africa. They are all intertwined. So we find out that largely the culture says that pain is a spiritual test, or it is the divine will. So I'm having this pain. Many cultures in Africa will say, you're having this pain because God says you have to go through it. God says he's putting it on you as a test. And we find out that in many of these African cultures, they tend to lean on their religious beliefs. So they tend to lean on their the religious articles they have, and prayer and fasting. And that's where they would gravitate to first of all, before they seek orthodox medical care, if they do that at all. And then there's a good thing that comes out of the religious influences. It's proven through research that positive religious coping improves resilience, while negative religious coping does the opposite. So let's talk about traditional beliefs and stoicism in regards to the child's pain expression. So here again, we're seeing the picture of the two young boys in the Sharo festival. They'll beat themselves up, and they'll flog themselves and flog, and they'll be so, and if you look very closely, you'll see a lot of scars, because that's what happens. Despite the scars, despite the pain, despite the bleeding, I mean, it is a valorization of bravery and endurance, where crying is seen as weakness, so they don't cry. So children are watching, and this is how the children will grow in that society and deem that crying is just no. Then, of course, traditional healers are primarily, as I said previously, the first contact for many of these patients, children and their families, before any of them would ever think of coming to the hospital. So what else would affect the expression of children's pain on this continent? When discussions are made about their care, children are rarely ever involved. And there's a reason for that. The reason for that is the culture says when adults are talking, you shouldn't be talking. Also, language barriers are problems because, for instance, in many cultures, there isn't a concrete word for pain in the language, okay? And then also, depending on the developmental age or stage of that child. For instance, the child is cognitively impaired, that would hinder the expression of their pain. Then on this continent too, nurses, doctors, other clinicians often lack training in pediatric communication and pain assessment. And then the parents are there as gatekeepers. They are the ones to stop you and say, no. And you as a healthcare keeper, you can't get adequate information to help their child because they're gatekeeping. So let's also now look at some culturally congruent strategies and some non-pharmacological ideologies that work on the continent. Let's talk about swaddling. So we know that research has proven that swaddling can help, give comfort to a child, placate a child, reduce the child. And that comes from Africa. We know that we were doing the babies at the back. We carry our babies at the back. They go to sleep. They are comfortable. So those practices are practices that we say, let's encourage so that it will be part of our armamentarium. And, that's why I'm so in awe of what St. Jude's Hospital, Children's Hospital, Research Hospital is doing with the Global Comfort Promise. Finding real interventions that work to reduce pain in children. And that's really remarkable. So, but in Africa, apart from swaddling or strapping a child to the back, storytelling is another thing that can be engaged in. And prayer. These are, and then even the parents being around or some loved one being around, these are distraction techniques, as we know. But then also herbs. Africans rely a lot on herbs. We see in South Africa, they take the aloe vera plant and they take that bitter juice from it for belly ache. So you have various kinds of plant-based solutions and plant-based herbs and things coming out to help with treat pain. These are things that, even though scientifically have not undergone rigorous scientific scrutiny, we can actually look into them and see whether there are things that can be eventually proven to work scientifically, validate them, and then commercialize them. But in the meantime, we have to have this at the back of our mind so that our patients, their parents and their families can relax and accept the care that we want to offer them, even though the care might not be herbs, might not be prayer and storytelling, but we don't discourage that because that is part of the culture. And then, of course, I talked a bit about the language issues and the communication issues, limited vocabulary, children not even being able, non-verbal children not being able to say they have pain or how much their pain is. Then we have very few pain skills validated on the continent. So many of us as clinicians in Africa, we're relying on validated tools for high-income countries that haven't been validated in the African context. And of course, language barriers. A lot of the time, some of us as healthcare providers cannot speak the language of the patient, especially for countries that have multiple languages. Nigeria, for instance, has 250 languages. I can only speak one. So if a patient comes from another region of Nigeria with his language, I have to look for an interpreter. And by the time there's an interpreter, there may be a lot of things that I may miss in the process of having the interpreter, the back and forth, and that can affect the management of the child with pain. Then the big one, which is silencing the child's voice. I mentioned it briefly before that when clinicians are talking with parents about the child's pain, they tend to talk over their head. And then, of course, we don't undermine the cultural influences that says when an elder is speaking, younger ones don't speak, no matter the age. So it stands. And we have to have that at the back of our mind and know that we don't, when we have patients like these children, we don't force them to speak where their parents are, but we can encourage their parents to ask them to speak and talk about their pain. So they are getting the affirmation from the parents. They're getting the permission from the parents that it's okay, yeah, to go ahead. Yes, the elders have spoken, you can now speak. I mean, those are some of the things that we can consider. Then, of course, we cannot overlook the problem with our health systems in Africa. Resource limited. We are largely resource limited, lacking staffing, lacking pain tools, and poorly documenting our patients' pain. And of course, we have limited access to essential medications. A few countries in their national guidelines have specifically talked about children and pain relief for children. And there are gaps in the nursing and physician education with little or no training for clinicians on how to take care of children's pain. Then, of course, we have research and evidence gaps. There are very few studies that give us the experience of the child from their own eyes. We don't have qualitative research that talks about cultural communication on pain. We don't have a lot of research that talks about how training for clinicians on children's pain management and communicating a culturally contextual pain intervention would look like. And so those are some of the needs that will help us refine what we do on the continent. Then, of course, the assessment tools. I mentioned that a lot of us are using validated tools in high-income countries that haven't been validated on this continent. But presently, only 5 sub-Saharan African countries have actually validated some of these skills in their national language. And those are some of the countries there: Ethiopia, Kenya, Tanzania, South Africa, and Cameroon. So there's a huge gap here, and therefore a huge need for culturally and linguistically validated instruments. So what are the solutions that I'm proposing this evening? And I think you'll be proposing the same with me as we go along. The first is we have to find a way to integrate cultural competence in our care of these children with pain on the African continent. We can do that by looking at the cultural beliefs, recognizing them, appreciating them for what they are, beliefs that are around pain, okay? And then educate the patients and their families about the good things about those beliefs and the bad things about those beliefs. Then we also have to learn culturally sensitive communication and then collaborative care with the families and traditional leaders. And like I said in the beginning, if there are traditional leaders or religious leaders that are part of the child's care, it won't be a good thing for us to push them away. So we can come together. We can ask the families, bring the traditional leaders that have been with you in this care, bring the traditional healer that has been part of this child's care for their pain or for their illness, so that we can all collaboratively care for the child in a proper way. There are some other practical strategies we can do is that we can go into the communities, engage with them, and try to dispel myths around pain management using orthodox means. Another thing we can do is also have the families educate them on how they can help the child when they're home, when there is no healthcare provider around them. The basic things they can do for the child's pain to help keep the child comfortable. We can also look at our systems, our institutions, and look at the policymakers in our countries and seek for them to integrate pain as a fifth vital sign in our institutions and ensure there's reliable access to essential analgesics, and of course, quality play and then pain documentation for quality matrix. And then there's no end to emphasizing on the need for research, having a lot of pilot studies from different regions of Africa to pilot culturally sensitive interventions and track the outcomes in so many ways. So briefly, just look at this case. Is a 13-year-old with sickle cell crisis, but he delays reporting his pain. And why? Because the family chose to use herbal medication, and not only the nurse who lives in the neighborhood severely underestimated the pain severity. So this is a lesson for us that despite this problem, we should learn about the beliefs in our communities around the beliefs that these patients have in their culture regarding pain and pain management in children. We should learn to educate the family, and of course, we should use child-friendly visual skills so that we don't make the mistake of using skills that are not appropriate because we can't get the right answer from a wrong tool. What do we recommend for policymakers, for policy and education? What are the main recommendations? I would say it would be good to integrate pain management for children as an in-service training requirement. And if we have the luxury in our various institutions, it can be a pre-service training requirement. We need to include documentation, because there's no way we'll know we're doing what we're doing is working or is right if we don't assess the quality. So if we don't use quality assurance metrics. So we need to assess ourselves from time to time and see, is the pain care for these patients adequate? Is it working? Do we need to step up? Do we need to improve? Do we need to change something? We also think, I recommend, and I think you would recommend along with me, that every national pain policy must be grounded in culture, especially around the pediatric pain guidelines. And then I think it's also time for us to think of creating an African pediatric pain network where we can sit together, validate tools, share data, and improve the management of pain on the continent. Let's not forget the importance of local idioms and storytelling. This is the bane of Africa. Africa is known for local idioms, metaphors, and storytelling. It helps children to better express their pain. So they may not relate to the Wong-Baker Faces Pain Scale, but they may relate better to stories out of Africa that you tell them, and they can tell you more about their pain when you tell them the story. Let's not forget color symbolism. In Africa, color is everything. That's why when you see our outfits, our local fabrics, they are in color, like mine, very colorful. And its color symbolism is big, is huge in Africa, and it's important. We can put that in our African pain scales when we validated them to enhance their effectiveness and acceptance to local communities. I think that this presentation will not be complete if I don't talk about artificial intelligence, because we're in the era of artificial intelligence, whether we like it or not. So what are we thinking about that? We are thinking that artificial intelligence has to be something we have at the back of our mind that would eventually come. So because we know it's here, we need to ensure that the AI tools for pain management are culturally competent. That means if it's a tool for screening facial expressions for pain, is able to pick the expressions for pain irrespective of the ethnic group or the ethnic group that the child falls into. We also have to make sure that those tools have a lot of data so that we're able to audit for bias, and then ensure that those systems are fair, they're inclusive, and they are respectful of the diverse cultural perspectives that Africa is known to have. Then let me make mention of the online pediatric palliative care curriculum. It's pediatric pain curriculum from the Sick Kids Hospital at the University of Toronto. It's an exciting curriculum with various aspects. There's actually a full module for pain in low middle income countries. It's all free. Just get into the website and spend time in all those modules. It's very free, comes courtesy of course, Sick Kids, the Hospital for Sick Children at the University of Toronto. So please check it out. So the key take-home messages here is that culture shapes the way children express pain and how their pain is managed. And we need to acknowledge family, acknowledge the religion, the influence of religion and traditional beliefs. Don't dismiss them. If we want to ensure that the care that we're giving these children who have pain is equitable, then we have to ensure that the care that we have a culturally competent education and communication assessment, and there is policy reform in that regard. So in conclusion, I want to say that cultural awareness would enhance empathy and improve outcomes for these children, and that culturally sensitive pediatric pain care is equivalent to listening, adapting, and partnering. Those are the three key words. Understanding culture is never an option. It is essential for compassionate and effective care. So thank you so much for taking out time to listen to me. And I'm very ready for your questions now. Thank you.
Thank you, Professor Onyeka. That was a wonderful talk. Really appreciate it. I probably have some questions, but first we'll open the floor for any questions from the audience. Okay, while we're waiting, Professor Onyeka, I was just mentioning I really appreciated your talk. As you know, we're in Sick Kids Toronto, we're one of the most multicultural international cities in the world. And knowing this cultural sensitivity with so many people immigrating from around the world, it's so important. I know I practice acute and chronic pain, and I know the one population that's increasing for us because of immigration is sickle cell disease, and we've had a lot of very challenging cases. So I just want to ask your opinion, just based on an experience that we had recently, what your experience is with adolescents with sickle cell who are also suffering from chronic pain. And if you have any insight into how you approach, teaching the families that the acute and chronic pain are very different, or any insight into, I'd love to hear it, because it's sometimes very challenging. I'm sure you mentioned sickle cell in your talks. I'd love to hear your insight into that.
Yes, yes. So it's really very challenging also for us, especially as Nigeria is the country with the highest number of sicklers in the world. In our practice, we tend to see them a lot, the adolescents. And what we find out is because there are not enough pain physicians, pain clinicians, most of the time they're in pain. So when they come to us, severe pain, we start them off on the opioids. But we also tend to have to sit down and talk with the families because these children are stigmatized. So we find out a lot of times that the families, parents, siblings especially, don't understand his real pain. They think that they're malingering. They think they're making up. They think it's in their mind. So a lot of it is not just the medication, but sitting down with the families to make them understand that it's real pain, it's not going away in a hurry, but we will try to reduce the pain and improve the quality of life of these children, of these adolescents. Another thing that compounds our care of the children is depression. These are young men, young women who are looking out, and their friends are moving out and driving in cars, and they're laying in the hospital bed for weeks on end. So also we talk to the patient. We try to encourage them, try to find out what they can do within the vicinity of the hospital. Try to have them plan for what they will do when they leave the hospital after admission. We don't have as many exotic medications as you would have in the high income countries, yes. So, and then we have a lot of stockouts. So a lot of the times we make use of a lot of non-pharmacological options. We use our physiotherapists too. We use them a lot. They come around to do the massage. They come around to do TENS where it's applicable. So that's how we manage that situation. It's not an easy situation at all. Yeah, but getting to sit down with the families at interval, sit down with the adolescent at interval, talk with a team, have a multidisciplinary team meeting about it, the approach that we're taking. And then, of course, the physiotherapists, they are very valuable assets to us. And then the analgesic medications.
Yeah, it's very interesting because we're very aware of the inequity in giving pain medication to certain populations. And I think we've done such a good job that when we admit some of the sickle cell patients, we focus entirely on medications. But I think what you brought up is such an important point that maybe we need to have inpatient physio and other non-pharmacological strategies. So, and majority of the kids come and they go home, but we have, some patients who, even when we discharge them, the impact on mood function is pretty significant, but they're so burdened by disease, it's very hard to get them into our chronic pain clinic and have all this. So hearing that you're doing the functional rehab approach, even in the hospital, is, something we could learn from what you're telling us. So it's really great. And I see my close friend and colleague, Dr. Campbell, has her hand up, and hopefully she'll put her camera on and ask a question.
Hi, Tonia, and thank you so much, Deepa, for the invitation to turn my camera on, but my office is in a total state of disrepair, so I won't. It's lovely to see you, Tonia, and your work continues to be so inspiring. I just wonder for other people who are here today, what have been some of the key enablers, like the facilitators, to really advancing your work in Africa? Because I know we have people joining from many different continents, and I think they can certainly learn from your approach. Yeah, thanks again, Tonia.
Yeah, thank you. Thank you, Fiona. So I'm going to say it like it is. One big resource that we've had that has helped us is the echo from SICKITS. I mean, I was on the echo for over a year. It is very stimulating. It is very instructive. And you have the ability to bring your case and talk about it. So having that community of practice, the echo from sick kids is a number one for us. That's a big number one for us. A second thing is ensuring that the care that we're giving these patients is multidisciplinary. So I'm not saying, okay, because I'm a pain specialist, I do it all by myself. So you can see that I talked a lot about the physiotherapists. I pull them in a lot. They come in a lot. They're part of the team. The social worker is part of the team because she's talking with the families. And sometimes I chip in, but she's the one talking with the families. And I'm the main team that owns the patient also. So the primary team that owns the patient. So that multidisciplinary approach to the care of the patient, those are the two big things. Multidisciplinary approach to care of the patient, pulling in the various specialties. And I don't joke with my nurses. The nursing care, I don't joke with that. So pulling in all of that, all the clinicians with me, say, we're going to do this together. And then, of course, attending the echo session. So I did that for over a year. I spread the word, and I'm hopeful most people have joined. And today they will hear about the echo from sick kids, and they'll join. So those are the two resources for me.
Thank you. Thank you.
In an environment that is so constrained.
Yeah, thank you so much, Tonia, and thank you for giving a shout out to the Echo. I noticed that one of the presenters earlier was talking about how Echo is being used in India. So people can presumably look on the Echo Global website to find out where all of the Echoes related to pain and palliative care are. And yeah, the link is, Cynthia's put the link in the chat about the Echo today. And couldn't agree more. This is definitely an interprofessional issue. Thanks again for your presentation, Tonia.
Thank you so much. Thanks for having me. Thanks, Deepa.
Thank you. And just as a wrap up, just want to thank you so much for presenting. It was a fantastic talk. I learned a lot. I'd love to connect with you actually about some of the sickle cell stuff. But thanks to everyone for joining, and it was a pleasure to moderate today. Thank you.